Anything.
I will not spill anything on. No, I wouldn't do that. Because if you have water damage, they're really just they're terrible at the Apple Store. I mean, there's no way you can get a refund. We're the forefront and the forefoot of all of this, all of us, and this is terrific, and we're extremely excited about this. But we'll more later. And we're also equally excited about this final session, and you guys are astonishing on this gorgeous day that you're hanging around for all this, and all of you at home. Whatever the weather's like, whatever time it is, you're in for a treat for these last three talks. The first person you've already been introduced to. In fact, all three you have, so I'm not going to go on and on and on. You'll be happy to know. Let's just introduce Spence Taylor, who's going to be talking about preventing amputations or preserving function. Professor Spence Taylor.
Thank you, David, and thank you, George, and thank you, Joe, for again for the invitation to come to this magnificent conference. It, as I've said, I think before, and have said often, it is a major contributor to advancing the knowledge to the people that actually take care of diabetics. So it's a real honor to be part of this. I will tell you that one of the more intimidating things that you can do in life is to be the person that presents the amputation lecture of the DEF CON conference on the last session of the last day of the conference. And, you know, it's a very, very intimidating. If you heard all these magnificent sessions where we've done everything we can to save legs, and then they've got the poor schlep at the end that's going to talk about amputations. I felt incredibly insecure yesterday at the Alamo's Advocacy for Limb Amputation Prevention luncheon yesterday. I was in the corner, back to the back, felt very insecure. And I just got to tell you, ladies and gentlemen, that my name is Spence and I do amputate legs. And I'm a member of Amputations Anonymous, and I'm working to try to get better at this. But just do know that this is indeed my plight. I will share with you through my experience, and this is very much a corollary to the talk I gave yesterday. For those that weren't here, it's a little more aligned towards this whole concept of matching the treatment of the patient to the desires of the patient, and what can we do from a functional capacity to maximize functional outcomes. And our approach to amputation has been really jaded by that perspective, I'll tell you. I'll share with you this. All these patients have a couple things in common. They're all diabetics. They all have a superficial femoral artery occlusion. And if you can look at this, if you start with the guy at the lamp pole, you can see he's got claudication. He's radically different than the guy just below him. There's a guy there that just finished the Las Vegas Marathon. A couple of people in the upper right look like they've already been to see the vascular surgeon. And I don't think I'd mess with the two people at the bottom. But the point about this is they all basically have the same disease. They have the same anatomy, but they're radically different. So why do we think that you should treat everybody, every single one of these patients in the exact same way, with the exact same therapy, so over the exact same time? And the answer is you really don't. And my philosophy, or what we've come to learn, is that limb amputation is not always a bad thing. Now, I know that that's heresy. There are people in the room that have completely turned me off, and maybe a couple in the back have had apoplectic seizures. But let me just say that there are times when, I think you heard from the panel before, that the amputation can be your best friend. So our interest in this dates back several years, probably almost a decade ago now, where we looked at, very much in the same vein that we looked at our critical limb ischemia patients, preoperative clinical factors that actually predict postoperative functional outcome after major lower extremity amputation. And in this series, we had about 550 patients, over 600 amputations, and we looked at functional outcomes and what were the determinants of functional outcome. This is was presented at the Southern Association for Vascular Surgery and published in the Journal of Vascular Surgery. And this is what we looked at. We looked at, in this group, it was about 70% diabetic, about 90% had some degree of vascular insufficiency, although much of it was subclinical in nature. And we simply looked at, if you took a leg off, either above knee or below knee, how many people were going to be wearing a prosthesis, and what are the odds ratios for this, and what's their functional status afterwards. And in this study, this is what we found. The independent predictors are the factors that people have that predict non-wearing of a prosthesis. And this is what they're listed. It's non-ambulatory transfer status. These are the people that we showed yesterday, Mrs. H. This is the folks that basically sit in the wheelchair most of the time and use their leg to go from the wheelchair to the commode to the bed. And those people basically, in our series of over 600 amputations, were the people most likely not to wear a prosthesis, followed shortly by above-knee amputation. And then homebound ambulators is, again, people that are somewhat incapacitated in terms of their activity, followed by age and dementia. If you look at factors independently associated with ambulatory failure, a lot of people, interestingly, wear their prosthesis for cosmesis. They'll put it on just because it has it keeps the sensation or the visual effect that you've got two legs, and that's important to the body and self-image of many of our patients after amputation. But where the rubber meets the road is factors that are associated with ambulatory failure, and this is listed here. The biggest risk, independent predictor of poor ambulation was age, greater than 70, followed by two categories below, age between 50 and 59, so age. And then bilateral amputation, which is somewhat intuitive. And again, your functional status is followed after that, and end-stage renal disease after that. These were all predictors associated with failure. Factors independently associated with mortality were age, and there were two. It was probably the biggest factor in this series that we had. And so, if you look at the study, we came to the conclusion that there are really two extremes. That there's two sets of players. There's the people that are totally old and poor functional status. And they had a poor outcome. They're not going to wear a prosthesis. They rarely wear a prosthesis. You could argue that, and we routinely will put in a prosthetic consult for most of our amputations, almost routinely. But in this group, if somebody is really, really old and they have poor functional status, the chance of them actually wearing the prosthesis and using prosthesis is really pretty small. That's one group. The second group, which was really quite amazing, these are the young, less than 60 years old, where you had any level of amputation, above or below knee amputation. Their ambulatory rates in this series were over 75%. And they had one-year survival as high as 87%. And so we kind of come to the conclusion that younger amputees with BKA can anticipate functional outcomes rivaling those reported after successful revascularization. And if you think back to the data I showed from our institution in sunny South Carolina of our functional outcomes in our patients with bypass, these numbers are very strikingly very similar. Now, radically different patients, different processes, but a nearly 70% chance of functional outcome is not a death sentence for these folks. It's really a pretty impressive number if you look at it. So we presented this at the Southern Vascular, and Dr. John Manick, who I have great respect, and many people in this room know very well. He got up to the microphone and he said, you guys down there in South Carolina seem to be cutting off a lot of legs. Are you sure you know what you're talking about down there in South Carolina? And so, I don't know if anybody ever in this room has ever even been to South Carolina, but the term South Carolina does conjure up a lot of visuals like this. These are the poor state of South. Here's the mayor of Greenville taking the first lady out to the S&S cafeteria last week. I got a picture of them. And you can see there are a lot of big people like myself, I guess, in South Carolina, which then begs the question. Well, maybe Dr. Manick is on to something. If 70% of good functional people or young people are able to get 70% of them are able to get good functional outcome, what about fill in the blank people? So, looking at the people in South Carolina, what about big people? What are big people? And then we actually looked at this. We looked and says, does obesity predict functional outcome? And our hypothesis was that when you do these amputations in really obese patients, they don't do very well. And so the people that are non-functional, the people that are old don't do it. But what about obesity? So we looked at this in a series of about 434 dysvascular patients who underwent major lower extremity amputation over about a 6-year period. And we did a retrospective study to look at the functional parameters of survival, prosthetic usage, maintenance of ambulation, maintenance of independent living status. And then we looked at multiple factors and confounding factors to see exactly which predictors of good outcome or bad outcome were present. And we looked at it over 4 different weight groups: the underweight, the normal weight, the overweight, and the obese, measured by body mass index. So if you look at the results, across the board, similar to our original study, about half the patients will wear a prosthetic overall, looking at it. And if you look at this, interestingly, our fat folks did pretty well, actually better than underweight. And it was the opposite of our hypothesis, that indeed patients that were underweight were statistically significantly less likely to use a prosthetic than the obese patient. If you look at overall survival for the series, it's pretty striking as well. You can see this is a pretty sick group of patients, 36% survival at 5 years. That contrasts to if you looked at the study we did yesterday, 1,000 critical limb ischemia patients, it was 42% at 5 years. So these are really critical limb ischemia and even amputation are really markers of poor survival overall going forward. If you look at survival in terms of their body mass index, actually the obese people held their weight better, no pun intended, held their weight better than the underweight people, but there's no statistically significant difference. Yeah, overall maintenance of ambulation overall was about 40% at 5 years, which is probably better than you would think. And if you look at size, the big people did better than the small people even with this, although it was not statistically, or it was statistically significant for underweight category. And then lastly, overall maintenance of independent living status was about 66% at 5 years. And again, we found very similar findings that our obese people basically do as well as our underweight patients. And so in summary, we felt like that amputation with people with peripheral arterial disease appears to be a poor marker of long-term overall survival, which we've known about. But actually, you're going to get about half of these people to walk. And if you're fat, you're probably going to be able to walk just as good as underweight, maybe if not even better. So an interesting finding that we had. This was really a little bit unsatisfying. We kept looking at this. Well, which patients can we select out preferentially? And it goes back to, are you going to be committed to doing long-term, many operations to try to save limbs, or maybe there's some patients that might just be, as somebody said in the last session, accept it, move on, and move on with life. So how could you measure a successful outcome after below-knee amputation? This is a study that I did with Corey Cobal and David called a few years ago and presented at the Southeastern Surgical. And so we did it very similar to what we did our cases with successful outcome after lower extremity bypass. And so we defined successful outcome after below-knee amputation as achieving all of the following: a heel below-knee amputation, maintenance of ambulatory status for 1 year, or if the patient died at the time, but within that year they were walking, and survival for at least 6 months, which again, as of yesterday, is code for the procedure didn't kill you, right? And then, this would be a successfully wound a heel BKA, and this would obviously be somebody that was successful in maintenance of ambulatory status that was able to get around. And then what we found was this: if you look at the parameters individually, about 86% of our folks were able to have complete healing and never needed to be revised. Maintenance of prosthetic ambulation for a year occurred in about 63%. Survival for 6 months occurred in about 86%. But if you put all this together, about half of these patients, 51%, had a successful outcome going forward. And if you look at a group of factors and try to figure out which are the independent predictors of whether they have a successful outcome or not, we found these 3 variables to be independent predictors of outcome: coronary artery disease, cerebrovascular disease, and impaired ambulatory status. And just like we did with success after lower extremity arterial revascularization, if you do this with our amputation patients, you find if you have none of these comorbidities, nearly about 67% of these folks are able to walk and have a successful outcome, compared to if you have all 3 of the independent predictors of poor outcome, only about 10% of the probability of having a successful outcome. So this is a tool that we've actually been able to use in our practice to help us determine which type of amputation to do, whether it's a palliative above-knee amputation or whether it's an all-out palliative below-knee amputation. And again, just a tool to help direct us in this perspective. So to summarize this portion, and I want to speak to one other really interesting fact that we discovered. Limb amputation, and it was said in the last session, we couldn't agree more, should not be viewed as a failure, but as a means to achieve an appropriate end. And we operate on a lot of limbs and save them, and we save most of the limbs that we operate on, probably 72% at 5 years for critical limb ischemia. So it's not an either or, it's a both and just understand that if you do an amputation, it's not a death sentence, and these people do have good palliative functional outcome, and some patients do better than others, as we described. But let me tell you, there are times, and this is a discovery, in which the non-acute and a non-acute setting where amputation actually may be preferred. So this was an interesting study. This was Dwight Kellicott and I, one of my fellows, we were looking at the perspective of what if you had these patients that were unsuitable for surgery. I showed you Miss H yesterday, somebody that just didn't pass the thumb test. You looked at it and said, I'm not going to operate on Miss H. Well, my sense was, and we were able to show in the data I showed yesterday in the state of South Carolina, what are people doing? Angioplasty. They're just doing angioplasty because it's tolerated, it's safe, cost $12,000, but it's safe and all good. And so our hypothesis was, if you look at functional outcomes, and if you took the people not suitable for surgery and did an angioplasty, I wonder if they actually do better than if you just went ahead and took their legs off. So we did a case-match control study, and we defined non-suitable for surgery as people with impaired ambulatory status at the time of presentation, senility, and two major medical morbidity and illnesses that we defined. And we did a case-control study of 314 cases, 314 amputations versus 314 patients that had angioplasty, both of whom met the criteria of unsuitable for surgery. And this is what we found. The people that basically had, if you look at ambulation, and you look at the people that had a percutaneous transluminal angioplasty versus the amputation, as you might expect, ambulation was better than the angioplasty group. But that advantage only lasted 12 months. After 12 months, there was no statistically significant difference, and the people that were unsuitable for surgery with the amputation did just as well as the people that had an angioplasty. What about maintenance of independent living status? We found indeed that out of the blocks, people that have angioplasty actually did a little bit better than people with amputation, but that advantage only lasted 3 months. So after 3 months, people with angioplasty and amputation do exactly the same from a statistical analysis. And then this was the finding that was surprising. The people that had amputations did better from a survival standpoint than people with percutaneous angioplasty. And that survival advantage lasted throughout the course of the study, which in this particular instance was only 3 years. So survival advantage was noted for people with amputation. That was curious enough for us to do this study. This was a study of 917 consecutive treated foot ulcers, and we presented the findings of this to the Southern Surgical Association a couple of years ago. And in essence, this was our total experience. And if you look at this group, about half of these foot ulcer patients had ischemia. About half of them didn't. All of the patients, to the entry of criteria was that they were diabetic. And what we were able to find is if you look at independent predictors of outcome, first, if you look at overall survival, and this is fairly striking, in this series of 900 patients, this group of patients, half with vascular disease, half without, had survival of only 39% at 5 years. That's pretty impressive to think how sick these people are. These are really, really sick people that you're taking care of that are probably at the ends of their life. And there's opportunity to improve here for sure, but this is a very, very sick group of patients. Then we found sort of an interesting phenomenon. We said, look, if you look at survival and you counted the ability to heal or not heal as not an outcome, but as a variable. In other words, if you can say if you were able to heal, you ended up in one group, and if you weren't able to heal, just as we showed in the other study, if you were unable to attain healing, your survival was statistically significant less than people that were able to heal, and it was marked. 51% at 3 years down to almost 30% at 3 years. So it's something about these wounds, these chronic wounds that these people heal that basically makes a survival. If you look at amputation-free survival, or these are the data, if you look at independent predictors for failure to survive, failure to heal that ulcer was probably more important than ischemia, age, end-stage renal disease, or hyperlipidemia. So healing the sores themselves is a predictor of survival. Pretty interesting finding. Very similar to what we found in our case control study. And it shouldn't surprise us since it's the same data set, but it just amplifies more indeed what you'll find. If you look at amputation-free survival, it's even more striking. People that were able to heal their ulcers had a distinct survival advantage versus those that were unable to heal their sores, 48% versus 19% at this time 5 years across the board. So if you look at it, wound healing itself is an independent predictor of survival and amputation-free survival. So don't putz around with them. You got to get them healed. And if you can't really get them healed, understand that there's something going on in the background, whether it's chronic inflammation, whether it's being exposed to multiple antibiotics, but it is actually a deterrent to overall health. And that's been what we found in our experience, which was a little bit surprising going forward. So, and these are the numbers. If you can see that with failure to heal in terms of amputation-free survival, these people, the biggest predictor of amputation-free survival was the ability to heal the ulcer. So a real bellwether and a real projective. Wound healing itself is an independent predictor of both survival and amputation-free survival. So, in conclusion, it is humbling to stand up at an amputation or a conference dedicated to the non-amputation of diabetic population and give the amputation talk, but I consider it a badge of honor. Yeah, but I'll tell you this, in conclusion, amputation has a therapeutic role in improving the quality of life. And in certain patients, it has been very, very liberating, as you've heard, and as hopefully I've shown you with this presentation. In the absence of predictors for bad outcome, success after BKA is attainable in almost 70% of cases. So it's not a death sentence. It's actually an opportunity to move forward in life. And in the presence of a chronic non-healing sore, amputation actually improves survival and amputation-free survival. And the moral there, the two stories are either get the sore healed or get the limb off is the bottom line. Again, I want to thank you for the opportunity to be here. It's been a pleasure to be part of this conference, and I look forward to the panel discussion. Thank you.